Our guest today is Chris Deacon. She is an attorney and a former public health official who led one of the largest public health plans in the United States as head of New Jersey's state health benefits program. In that role, she pushed for really aggressive reform and transparency. And since leaving government, she's become a national advocate for employer empowerment. She's testified before Congress and numerous state legislatures. Chris has recently authored a book. It's called The Great American Healthcare Heist. The Great American Healthcare Heist: Why We're Paying More and Getting Less. And for those who are viewing this on video, here's what the book looks like. Um, Chris, just to open up on a personal note, I've had the great privilege of knowing you and interviewing you and listening to you speak over the past few years. I just have to say, just because I really feel this and I deserve you, I think you deserve the credit here. You are one of the most knowledgeable and also one of the most courageous individuals I have met in the healthcare industry. Really, just from the beginning, you go for honesty and truth and transparency and integrity, and to the point of, quite honestly, risking your own careers. It appears to me, numerous times over and over again. Your book is, as I read it, it is on par with everything you've dedicated your career to. So just congratulations on the book. And again, I take my hat off to you in terms of what you have been doing and continue to do in healthcare. So that's a long welcome, but welcome to creating new healthcare.
Well, thank you. And honestly, thank you for those words. It's so nice to hear. It is a long road, but yeah, it's just great to hear that. And thank you so much. And I appreciate you as a clinician and a physician working in the system.
Yeah, I would pass that on to all the folks who are out there who are doing the hard work every day. So your book, bold, bold title, The Great American Healthcare Heist: Why we're paying more and getting less. Can you, I know this is a huge, huge topic, but can you sort of distill what's the big idea behind your book? What are the major messages you really want people to understand and take away?
Yeah, that's a great question. So, what the purpose of the book, or what the intended effect, if you will, um, when you read this book, I want you to then walk through life with a different lens, right? After you read this book and you go to an NFL game, or you go to an MLS game, or you're just driving down the highway and you see the local hospital's name on a jersey, or you see the newest hospital tower going up, or you see an advertisement on TV, you will look at the world differently after hearing some of those stories. Again, that's really the intended impact here.
Hmm.
Because once you see it, you can't unsee it.
Hmm.
So I'm
That's
I'm hoping it has that
Oh my
effect.
God, that's Chris, that's so brilliant. I have to tell you, and no one really says what you just said explicitly. And of course, the book, the way you do that, you sort of peel back the layers. Actually, you remove the curtains. You are one of those, I think, people who really you've been so deep under the surface. And again, being a lawyer, knowing how the contracts work in detail, knowing how the payment works in detail, knowing the incentives, the disincentives, all the clauses. This is really the devil here. I have to say, the devil is in the details. That could almost be, kind of a different title for your book, because the devil is really in the healthcare details in the United States.
Thanks for that next title. I'm going to write that down for sure. And it's the legal background is definitely, it's not only in the contracts, but if you look at the behavior of a lot of the entities that I talk about in industries I talk about, it's also like, how do I come up right to that line of legality, right? How do I get as close to that line as possible? Because we do hear that from a lot. Well, it's not illegal, right?
Right.
I'm doing what corporations do, and I'm making money. And if that's following this path, or if I'm private equity, there's no limitation on this. It's not illegal, right? I can't tell you how many times I've heard that. So understanding, that line
Hmm.
and then helping legislators and policymakers figure out how to redraw those lines.
Mm.
You know, we're in the very early, I think, stages and of getting it right,
Hmm.
but it's worth trying.
Yeah. Could you give an example? And there are, it seems to be hundreds in your book, hundreds examples. And I was just, when you started talking about it, my mind went to some of these things like the whole PBM. Uh, I don't even know what to call it. What name would you give it? It is so, it seems,
Let's
I don't know.
let's stick with the New Jersey girl, and we'll go with racket.
Okay.
That's
Okay.
a good one.
That makes sense to me. It really, when you start to hear how pharmacy benefit managers, the whole game works between pharmacies, it's and how it just you scratch your head and you say that can't be true, and yet it's been true for decades. And so, could you give an example of something that would fall under your term racketeer in that domain, or if you have another example, just to give folks a sense of what we're talking about?
Yeah, I mean, I'll give sort of a retail patient example, and then maybe I'll go a bit deeper from an industry perspective. I just heard an example of a member who was at a pharmacy, and the it was an independent pharmacy, and the cash pay price was like $17. But that individual was then redirected to a preferred pharmacy from their PBM, right? Um, and they would get a $0 copay. So $17 zero, they went with the zero. In the end, that $0 drug to the patient cost the health plan $10,000. Now, I'm sure there was a rebate involved that, perhaps the employer didn't pay the full 10 grand, but it sure as heck didn't pay 17. And these are the types of things as a member
Hmm.
or a patient, you don't know, and you can't blame me for going with the $0 copay. But this
Absolutely.
is part of the system,
Hmm.
right? And part of the perpetuation of the problem. Another example is, the introduction of biosimilars, right? We were really excited about it as an industry.
Hmm.
Um, but what I've seen is as biosimilars have gotten on the market, especially for a drug like Humira, which was, a really big budget item for a lot of employers for a very long time. The biosimilars entered the market, and the biosimilar strategy being sold to employers is, if you use this biosimilar from this drug channel at our specialty pharmacy, you're going to get this great deal. This is our biosimilar strategy, right?
Hmm.
Turns out that entire channel, up until the like actual manufacturer, they're white labeling, and they actually own the distribution channel, right? There's a, a couple of the big PBMs, they have offshore entities that are taking the same drug, white labeling it and then, distributing it through those channels. So now they're getting margin all the way up the chain. And they're selling it to employers as this great thing that they've come up with to save them money. It's just, these stories are endless,
Wow.
which is sad.
And I think that's the point. You could, I know you could, we could spend hours just one story after another of this, kind of racketeering type activity in throughout healthcare that, again, I- I- thank God there's growing awareness and some action being taken at the federal level. Why, if I'm someone, I'm listening to this and it has a bit of a macroeconomic, flavor to it. Why, as a patient, as a family member, why, as a particularly physicians, like with my physician hat on, look, I'm seeing my patients, I'm doing the best I can. I think I take good care of my patients. This is stuff outside of my domain. Why, even if I'm in a value-based care organization where we're trying to lower costs, which actually, I think that's an interesting opening there. But why should the average, individual care about this who's not trying to change it, or should they be trying to change it? What's your kind of what would you say to folks?
Yeah, I think that there's this sort of this fallacy that I'm not part of the system. It doesn't concern me, like you're just average member of the public.
Mm-hmm.
It doesn't concern me, and so, why should I care?
Mm-hmm.
Well, I hope that part of the purpose, again, of the book is to demonstrate just why you should care. And so I think we should talk about both the financial and the actual health consequences
Mm-hmm.
because they're both very real.
Mm-hmm.
So from a financial perspective, wages have by and large stagnated, not because employers are trying to keep their bottom line flat, but because healthcare costs have eaten up more and more and more of the budget. In New Jersey, the plan for a family PPO plan for our police and fire
Mm-hmm.
is around $60,000
For a family.
for a family, and they're paying 30% of that.
Wait,
They're
wait, wait.
highest earners.
60 per year?
Yes. Yes.
$60,000 per year for a family in New
Yes.
Jersey for
So
state
when they go
employees.
to the bargaining table to seek
Wow.
a raise, they might get a great bump. It's just eaten up. In some years, it's gone, they've gotten a negative take home because the healthcare costs have gone up so much more than their wages did. Today, I would say most Americans that get health care from their employers, and self-insured ones, they think that the insurance carrier's eating it, right? When they go to
Mm.
the hospital, oh yeah, Aetna paid it, United Healthcare. They think that's the risk-bearing entity, but it's not. And even if it is a fully insured product, you're just going to get hit with that premium in the next year.
Right.
So, yeah, I mean, I think not that I'm advocating for this,
Mm.
but if an employee were to get their wage check, right, their payroll, and then have to actually write a check for their health insurance, I think we'd be having a very different conversation. Because you're right, it's like it comes right out. I don't think about it. And so there's this
Mm.
mentality that like healthcare costs go up, I don't see it. It just comes right out of my wages. So I never actually see those dollars. So
Right.
I tend to discount them. But
What kind of conversation do you think we would have if instead of it just for the past few decades being silently taken out of our wages, what if in fact we actually had to write that check? What do you think to the employer or to the insurance? What do you think would change? What would happen?
Well, because the employer is the one responsible for contracting with the carriers and actually buying the health coverage on their behalf or buying the healthcare services even on their behalf, I think that the accountability would be much greater, right? If I had to write, if
Mm-hmm.
I was writing $100 check 10 years ago and now I'm writing a $900 check, I'm really upset with my HR department,
Mm.
right? And we probably wouldn't even have gotten there because the employees would have been so upset, right, that something would have happened, something would
Mm.
have changed, because HR would have had to figure out a way to control costs and not just be sort of a
Right.
passive acceptor of whatever was handed to them by their broker.
Mm.
There would be a lot more active
Mm.
management. You'd manage it like risk.
Right.
I
Mm.
again, I mean, I think that, I'm not advocating for that model, but
Mm.
that awareness is what is missing, I
Mm.
do think.
Mm.
And so to go back to so that's the financial piece.
Right.
On the actual healthcare, like care clinical side, I just saw another study done that just came out a couple days ago about how Medicare is paying for unnecessary back surgeries, right? So they've gone back and they've done an audit and looked at records, and 40% of these surgeries were unnecessary. Now, for anybody that's had a back surgery,
Mm.
you know that that's not a no harm, no foul because I didn't have to pay anything. That is a real life consequence.
Oh, sure.
There is, possibility of hospital infection.
Wow.
When have surgery, like maybe you're not playing with your grandkids for a few months, really valuable months, right? Maybe you're forever impacted. The
Hmm.
number one cause of spinal fusion surgery is a failed spinal fusion surgery. So when we talk about the financial incentives and driving, you know, um, overutilization or inappropriate care, unnecessary surgeries,
Mm.
it's not just the financial. Like this has a massive impact on people
Yeah.
and their ability to live their everyday lives. And they don't know that their bodies are being preyed upon. And I honestly think
Yeah.
that that's what it is.
What do you think are, what is directionally the solution, or what are your thoughts about, given the problems you've seen here?
Hmm. Thank you for that question. Because it wasn't sort of if you had a magic wand, what would the solution be? Because I think that's a really difficult question and one that isn't necessarily smart, to answer and spend a lot of time on because it's direction. What direction should we
Yeah.
be going? What are our guiding principles for our
Mm.
path forward?
Yeah.
And for me, it might sound overly simplistic, but I think the closer we get
Mm.
to having, the closer we get to a provider and a patient having an interaction, both,
Mm.
from a financial perspective and a visit perspective. And when I say that, I mean, we need less middlemen. We
Mm.
need less folks that are feeding off the system that
Mm.
need to milk it for their revenue and for survival,
Mm.
right? So, what is an example of that in practice? I would say it is, having a member and, the ultimate purchaser, maybe the employer, having a direct relationship with a hospital, right? And maybe it's a direct contract because I don't need
Mm.
Blue Cross Blue Shield or United to negotiate a discount that's actually higher than the cash rate, right?
Right.
Um, so again, I think the closer we get to restoring some semblance of the relationship between the provider and the patient, where our providers are practicing medicine and telling us what we need, that begins to foster trust in the system
Mm.
that we need from providers, right? Because we need them to believe in the system too.
You're right.
And it begins to foster trust from the patient, which is sorely missing today because of the system. They continue to feed this system more and more money upfront in premiums and then also in out of pocket, before they can even begin accessing care, they're asked to pay more. And for what? What are they getting from it? Right? Again, so it goes back to sort of the title, paying more and getting less. I think that that is absolutely the sentiment for a lot of people,
Mm.
but they don't understand why,
Mm.
right? They don't. And I think that, part of the point of the book too is for a resource for people, who are asked, well, why is this a problem?
Mhm.
And it's bigger than just direct to consumer advertising for pharma. And it's bigger than just the big bad insurance carriers and denying care and delaying care.
Mm.
It is a systems problem. We have a broken system that produces, that can produce a miracle and does great things, but it's a broken system.
Do you have an example of that directionality? I love that, by the way, that it's almost kind of like Back to the Future. It's like, listen, the value proposition here is your provider and you. And there's a lot of stuff that's happening around that and between that that's adding a lot of cost without a lot of value. And in fact, I'm sure you're familiar with these graphs that show that over the past like 20 years, the increase in physician cost is just very, very slight. It's a slight gradual. Yeah, it's pretty close to flat. But then you look at the administrative burden and it's just a mountain. It just goes like this. And so we've added extreme administrative costs and overlays coming from multiple stakeholders and across the industry. And yet the true value is actually in that provision of care. Do you have an example of an organization or a system or a market that is kind of moving in the direction you just described?
Yeah, I mean, I think the perfect example is like a direct primary care that's
Mm.
working directly with like an employer or a union. And there's several great examples of that happening. Some in New Jersey, but a lot around the country.
Mm.
And what I find so remarkable is that we in the benefits industry are describing employers that have this, who've hired a primary care physician for their employees, um, and allowing them to directly connect more often with no barriers barriers to entry, we're calling that innovative. We're calling it disruptive. We're calling it, something,
mm,
like you said,
mm,
it sort of sounds future based.
mm,
How sad is, I think it's sort of a sad state of affairs that
mm,
we are calling innovative
mm,
restoring a simple relationship between a patient and their primary care physician.
mm,
I,
mm,
that shouldn't be super innovative, but in today's world, it is because we've gone so far astray
mm,
from that.
mm.
So, I mean, I think that's a good example of that in practice. And whether that can be scaled nationwide, that's a debate for another day. But from a directional perspective, that's
Right.
spending the dollars in an intelligent way. I'm investing in my people. I'm
Mm,
trying to keep them healthy
mm,
because, we really should only be sending people to the hospital when they
right.
really need that care until the chassis, if you will, of healthcare is rebuilt and remodeled. What we build on top of it is always going to be fundamentally broken.
And that kind of brings us back to, what you have been doing in terms of, the legal part, the policy part, legislature, really, saying this is the way it's going to be paid for. I mean, someone has to change the game, right? Someone has to change the rules of the game, and that's not going
Right.
to be the industry.
Right. As much as they want to tell us that they are going to self-police, I think we can look back in history of big corporations and find that that is probably not likely to happen. And so herein lies the dilemma. You now have an industry who controls 20% of our economy, is usually the largest employer in their local communities. They have tremendous political influence and sway not only because of their size, but because of how they work in their communities and that they're a huge employer. So the folks that write the rules
Mm,
that should be adjusting that line that they're supposed to go up to legally, um, are largely, beholden to industry. And whether that's the hospital industry or the carrier industry or
mm,
pharma, New Jersey is head of it, a pharma capital, right? You will not see any New Jersey legislators looking to, harm pharma in any way.
wow.
So I think that, that's got to be part of the solution is how do we solve for the really undue influence that is being exerted in DC and hold our political like leadership accountable. Like we are the voters, right? And this goes back to why did I write the book, right? We
Mm-hmm.
need, one of the last untapped resources in this fight
Mm,
is the wrath of the American people,
yes.
right? And it is their power in the voting booth, but
Mm.
they don't know what to do if they don't know what's happening.
Well, first of all, totally agree with you. And yeah, you brought it right back to the book and the purpose. I was smiling because, in the beginning you said, I want people to kind of see those signs on the buses of healthcare systems and pharmaceutical companies and this and that and have a different understanding. I get to go to New Jersey quite a bit. Just like you, I was raised there, and so go back to see parents and in-laws and on a frequent basis. And driving down Route 22, I think it is, and there are other kind of streets or avenues where
Right.
there's left and right. There's just one pharmaceutical company after another, and I've been driving by them for years. The next time I drive by them, to your point, I will have an additional thought about them and the influence they have on policy and legislature in New Jersey. And
Mhm.
you've now given me a different perspective as I'm driving by those companies and seeing them and realizing the impact they have on the industry and the stronghold. How can people learn more? And actually, is there a contact? I mean, obviously your book, again, the Great American Healthcare Heist, Why We're Paying More and Getting Less by Chris Deacon. It is well worth reading. How can people learn more about it? Is there a website you would recommend? And final question, I'd like you just to go into, which is there are so few people who actually understand what you have written in this book. And if they did, and they realize the impact on their lives, their careers, their wages, their families, how much of the resources they could be using to other things in their family have been taken up over the past few decades by healthcare costs, which are not really making them healthier. Um, you know, how is there a way? I mean, is there a video? Is there a documentary? Is there a way to actually get this out there in a way? Again, this is complicated. I've been studying this for years and years, and I still find it incredibly challenging. And then when you actually get into the finances and contracts and economics of it, it gets PhD like.
Right.
How can we you can get this out there to actually get people aware so that they could start to voice their concerns. And I think it would be outright anger and outrage.
Yeah, so there are a couple videos or documentaries out there. Unfortunately, there are not many materials that,
Mm,
because it is so complex by design, because it's been a great, great boon to the industry to be able to say, don't worry about it,
mhm,
it's too complicated, right? And we've bought into that. Um, so I mean, me personally, like I'm very active on LinkedIn and I'm starting a Substack, so you don't have to be on LinkedIn to review the content. But I would say talk to talk to your neighbors and talk to if you share this information when you get it because it could be invaluable. And again, if you're uncomfortable talking about money, that is totally fine. There is plenty to focus on like the health part of this and the actual human impact. But sort of I'll give you an example of how this works in practice and how why it's important for people to have even just some of this knowledge.
mm,
My mother-in-law was on a Medicare Advantage plan, and she went to the hospital. She had a cough, and
mm,
she had asthma in her early childhood, but not a serious asthmatic, and she just needed some medication. So she went to the doctor, and he said, He coded her as a severe asthmatic and gave her a prescription. She said, no, I'm not a severe asthmatic, right?
mm.
And he pushed it, and she pushed back. But the doctor said, well, it's already in your chart. I've already put it in the EHR. It's not a big deal. It's just going to show that. So if you ever need anything. And she didn't let it die.
Hmm.
And you know why? They were upcoding her risks
Upcoding. Yes.
so that
Explain.
they could charge more for her life,
That's exactly right.
right?
Another
And
diagnosis increases the amount you get paid for that visit. Yep.
and that severe asthmatic
Mm.
risk score is substantial.
Oh,
But
wow.
we had had a discussion about Medicare Advantage, and I was telling her about how
Mm,
the finances work. Like, yeah, you get capitation, but then if you are a higher risk, you
mm,
get, the carrier gets more for you to better care of you because that's the value-based idea, right?
mhm,
Well, she knew this, and so she was able to point it out, and
mm,
she didn't let it die.
mm.
Um, but again, that's the going through the world with your eyes opened in a different way.
Yeah.
And so whether it's that type of information or,
Mm,
asking for a second opinion
mm,
or, questioning when somebody says, oh, that's $0. Well, how much does it actually cost? Can I know what the drug costs?
mm.
Um, just this the awareness to ask questions. Like, don't just blindly trust.
Yeah. I think, I think it's very hard for individuals. I don't think this is my opinion. I don't think we can put the onus on individual patients to do this or family members. And I speak now not with a professional hat on, but with my, patient and family caregiver hat on. It's very, very hard in the moment. And I think part of the challenge is, and this is part of the challenge, and I think it's important to say this, doctors, nurses, PAs, I mean, the staff, hospital systems, pharmaceutical companies. I mean, there's a lot of good that these individuals and these organizations are doing, and they are saving lives. They are curing illnesses, and so there's that good, and that's often used by the industry to defend itself and to kind of put a cover so you don't actually look at what's happening and all the bad.
Mhm.
And I think we can recognize the good and at the same time say yes. And there's a
Yes.
whole bunch of shenanigans, racketeering, waste that is actually, and the problem is it's not net neutral. It's harming Americans.
Before we wrap up, just
Mhm.
because you put it so beautifully, um, in your last comment about harming Americans, right?
Mm.
That there's a lot of good, and right, um, not only are we harming Americans, we're harming our miracle workers. I believe
Yeah.
we're harming our clinicians. We're
Mm.
harming the system that provides the miracles and the life-saving treatments.
Mm.
So that good that's paraded by the industry, right, to sort of shield
Mm.
the messy underbelly, they're part of this. They're a victim too, in my
How
opinion.
so? How so?
They are forced to be part of a system where they are no longer practicing medicine as, probably as they had anticipated and, wanted to practice when they first got into medicine. So if you're, for example, a primary care physician who's been bought up by a hospital, because it was the only way you could survive, you're not you're not viewed as your churn and throughput in order to refer to your hospital, right? Refer more imaging, refer more labs, refer more specialty visits. You've become a feeder yard for the
Mm.
big system.
Mm.
Um, so I think that, I mean, a variety of ways that we've commoditized not only patients, but the providers of care, um, is a really sad state of affairs. So, so yeah, the yes and I think not only are we harming, Americans,
Mhm.
um, but I think we really need to take care of our providers and structure a system in such a way,
Mm.
that there's not so much moral injury.
Thank you, Chris. I can't think of a better way to end this really, really wonderful conversation with you. I literally, I just after reading the book, I could talk to you for hours and listen to you for hours. So thank you, Chris.
Well, thank you for having me. And, yours was when I was sort of early in my healthcare career, was one of the podcasts that I credit with like bringing me up to speed. So I truly appreciate it. And it's, full circle now being a guest. So thank you
What
for having
what do they say? The student surpasses the teacher. So thank you.
me.
Thanks so much. Hope to talk soon.
Thanks.